Hello, good morning. Thank you very much for the invitation to talk, Catherine. I'm aware that I stand between you and dinner, so I'd better get on with it. What I'm going to talk about is imaging considerations in patients with ocular melanoma, but I'm a GI radiologist and I don't want to be didactic. I just want to sort of share experience I think we have quite a lot of experience of imaging patients with ocular melanoma, and I'd just like to share that experience with you today. I'm not making any particular statements or barriers, and in fact if I was, I'm sure you'd probably drive around them anyway. My colleagues, wherever I've worked, seem to be liver surgeons, easily recognisable by their special theatre masks. It's my job to identify colorectal cancer metastases in general. That's the major thing that I do, so that they can then do this and chop it out. Now that's basically what I've grown up doing. I trained in Leeds. This is an MRI on a patient with colorectal metastasis. She's 42 years old with 2 young children. This is back in 1995. This was some research we were doing with iron oxide, which makes the liver black and the metastases stand out more clearly. And the additional metastasis in the left lobe becomes apparent, and she was still operated on by Peter Lodge. This was in time in Leeds, and he wedged that small metastasis out and was able to get rid of the rest of them. That's my sort of background. Fittingly enough, I went to Sheffield, which is the home of stainless steel, and shortly before I arrived, Ali Majid was setting up the new liver resection service in Sheffield, so it was a fantastic time. This was a completely virgin territory. We were up and running. It's a typical example of perhaps one of the more extreme cases. This is a 34-year-old lady who's had colon cancer. I know that's a colon cancer metastasis because it's been resected. Unfortunately, a year later, she developed another one. That was resected. Several years later, fairly disastrous appearance. It's about this time in the mid-2000s that very effective chemotherapy was introduced, and one of the oncologists treated this lady very successfully, and Ali was able to go back in and do a third operation and remove it. There she is 1 year post-op, and that is 5 years post third liver resection, and she's now been discharged. So that was our background. Now, as you already know, Sheffield is a centre for ocular melanoma, so it didn't take too long before our ocular friends came requiring the services of the liver surgeons. This is a small project that one of our registrars did a few years back. We primarily screen with ultrasound. This is 61 consecutive patients whose ultrasounds are abnormal. They've all got ocular melanoma and abnormal ultrasounds. We have a very low threshold. We go straight to MRI. It's not all bad news. 15 of these people had completely benign disease. And that's a point that I'd like to make. Most of them were reported as metastases. And one of the things about MRI is it's very good at telling the difference between benign and malignant disease. There are 2 lesions within this liver, but on MRI I think they're more clearly seen, but more importantly they're completely different. This one is benign and this one is a metastasis. This is another CT scan. You may think that they are 3 cysts, you may not. There are 3 cysts. The smaller one is that one there. The odd lesion is a colorectal metastasis. It looks completely different on MRI compared to CT. It was these single-shot T2 weighted sequences which were very successful at characterising these small benign lesions. Hemangiomas, very typical appearance on MR, very different appearance on ultrasound. Other problems we have, fatty livers, easily identified on MR. You get all sorts of spurious lesions which are easy to tell this is benign disease. This is a patient with melanoma who's got a fatty liver and 2 small lesions in the liver. One of them is focal sparing in a fatty liver, and the other is a hemangioma, both benign disease. Very simple, easy to do. I remember this lady, she had 5 or 6 small lesions, echogenic on ultrasound. This looks like focal fatty change. We were very odd about this, it was very curious. She was newly diagnosed with ocular melanoma. We actually biopsied one of these lesions, it was focal fat. Fat people don't go well with ultrasound, I'm afraid. We have several cohorts of patients who we actually do MR on them. We do 6 monthly MRs, particularly large patients, not particularly good for ultrasound. It's a bit like driving through fog. But that doesn't mean everyone is bad at ultrasound. In fact, ultrasound's fantastic in most people, in my opinion. We have lots of people who've got lesions identified on ultrasound that are completely invisible on CT. And it seems to me that lots of people are using CT nowadays, and it was interesting about that data from the States. If I had one message today, it's don't trust CT. There are reasons for that, which I'm going to share with you today, hopefully. That tiny little lesion on ultrasound is a metastasis, and it's only about 5 or 6 millimeters. It's easily visible on ultrasound. That would never be visible on CT. Some of these small metastases are actually quite difficult to see on MR. This is a lesion which was picked up in a melanoma patient. You cannot see that on CT. If you struggle hard, you might see something perhaps. This is a T1 weighted image, a T2 weighted image. You struggle to see it. And the latest kid on the block in MRI technology is diffusion weighted imaging, and I'll talk a little bit about that later. And here it is, you can see it. But ask yourself the question, it's easy to see this on ultrasound. Ultrasound is portable, it's cheap, it's readily available. Lots of our patients come long distances. They can have their ultrasound at the same time they have their clinic visit. We provide an instant access service. We cannot provide that service with MR. But we have a very low threshold for MRI. As soon as the ultrasound is abnormal, we go straight to MR. But we can't provide that instant access. In that study that I showed you, 46 patients that had liver metastases. Curiously, 15 of them went on to have CT scans. We know they've got metastases. 3 of the CTs are completely normal. 7 underestimated the disease, and it was only 5 where there was correlation. That's a correlation in about 1/3 of cases. So why is CT so bad, yet we use it routinely for other cancers? I've nothing against CT in particular, but there's something quite peculiar about melanoma metastases, which I'm going to try and explain. CT is brilliant for looking at elsewhere outside the liver, but since most of the metastases seem to develop in the liver first, it seems that there's a key weakness of CT. Just because you can get everything in one place doesn't necessarily mean that the quality is what you require. I particularly like the bit reduced to 20p. This is the reason. That's an ultrasound scan of someone who's got a very abnormal liver. This is actually a lady with breast cancer. So obviously worried about that. She could not have IV contrast because she had renal failure. This is another problem. CT is dependent on IV contrast. And there's an MRI. You can see that in fact there's diffuse replacement of the whole liver, unfortunately. CT is rubbish without contrast. Now, this is a CT through the upper abdomen of someone whose ultrasound was thought to show a big spleen. And the theory was that it might be lymphoma, so they had a CT scan. Now this is an unenhanced scan. This is an early so-called arterial scan, and you can see that triangular structure is the spleen. In fact, the spleen and the stomach enhance, but have you noticed the liver is not enhancing? But if we go a little bit later, the liver enhances. And this was already touched upon this morning in the nice talk that we got by Neil. And I'd like to try and explain it like this. The liver has two blood supplies. The arteries that supply the abdominal organs go straight to the spleen and it enhances, and the gut and it enhances. There is an hepatic artery, but the reason the liver does not enhance is because there's a second blood supply from the portal vein, where the blood from the spleen and the gut drain to supply the liver. Now this is a much bigger blood supply to the liver than the hepatic artery, and it drowns out the effect of the contrast. So when the aorta enhances, the spleen will enhance, so does the gut, but the liver doesn't. It's only when the portal vein enhances that the liver enhances, so there's a delay. And so we get this so-called two-phase liver, the arterial and the portal venous. Now if you take a straightforward metastasis, it's barely visible on the pre-contrast scan, and in fact it's invisible on the arterial scan. But it's nicely visible on the portal venous, so it's important that the timing is done properly. If you look at the unopacified hepatic veins on the arterial scan, it's too early. The blood leaves the liver via the hepatic veins. They've still not got contrast in them. Now here's another example that's too early. You can see the hepatic veins, and they're like spaghetti, so they look like little round circles when you cut across them at the bottom end of the liver. Now if you go a little bit later, you'll see that those round circles fill with blood, so they become contrast, so they become white, but now you can actually see the metastases, which are completely invisible. So mostly we do portal venous phase imaging. But it's not as simple as that. This is a patient with renal cancer who's got a vascular metastasis that lights up in the arterial phase, but becomes completely invisible in the portal venous phase. This is an MRI scan. It's easily visible without IB contrast. There it is in the arterial, and it's disappeared in the portal venous. Now this is a so-called T2 weighted MR and a T1 weighted MR, easily visible without any contrast agent whatsoever. And I think the problem with these metastases from ocular melanoma is they have variable vascularity, and I think they enhance and disappear, and they're very difficult to see. This is a patient who's had a Whipple's for we were told a pancreatic tumour. This was a very confusing picture in the arterial and portal venous phase. On the MRI it's actually quite straightforward, these are all metastases, but in actual fact what's happening here is these metastases are hypervascular, and what we weren't told is that this was a peculiar type of pancreatic tumour. It was a neuroendocrine tumour, and these vascular tumours are very difficult if you start to give contrast, because it gets very confusing. Is an example of another one. This is a carcinoid, very vascular tumours. The arterial and portal venous phase of the liver, you just see the small cyst. On the MRI you see some lesions, and you'll see that what happens here is it's not very good with a straightforward contrast agent. But this is a new type of contrast agent. It's a liver specific. It's taken up by liver, and only the liver goes bright white. And now you can see the obvious problem in the liver. Now the reason I mention all that, because it was also mentioned about the people from the States. What they call Eovist is a contrast agent we call Primovist. It improves detection, there's no doubt about it. These tiny little lesions appear. This is about the limit of our resolution, about 3 or 4 millimeters. We can't do better than this. But on T1 weighted imaging, we don't know what these little zits are. So we go back to our T2, and you'll see that this one is benign, whereas on this one we can't see it, which tells us that it's almost certainly bad news. And in fact that was resected. It was a colorectal metastasis. So what has all this got to do with melanoma? Well, this is a patient who's got a target lesion on ultrasound, went for an MRI scan and declared that 17 years ago he had his eye removed. 17 years ago. Now, this is completely the wrong way around. This lesion is bright white on T1 and it's black on T2. Now remember the contrast agents I told you, we could make the liver black with T2. Why would you make the liver black when you're trying to find something which is black? And why would you make the liver white when you're trying to find something which is white? This is illogical. And the reason is, it's this stuff. This is melanin. This is the pigment. This was resected by Ian Cameron, who was one of our surgeons who now is in Nottingham. And you can see this is a melanoma metastasis 17 years after he had his eye removed. To my knowledge, this patient is still alive, and this was 2004. So, going back to our study, this appearance of bright on T1 and black on T2, it's very common. About 2/3 of melanoma metastases, ocular melanoma metastases, have this pattern. In about a quarter of the patients, there was more extensive disease on MR than there was on ultrasound. And they're the reports. This is a typical pattern, these bright white blobs. This is absolutely classic of melanin on T1. You'll also notice that fat is bright. So if you actually use a sequence which gets rid of the fat, they stand out even more clearly. So this is one of the standard sequences I use to detect melanoma metastases. But they're usually mixed. So if you notice in this liver, some are bright white and some are not. You can already see this patient's had a resection of the liver. CT suspects that there's a recurrence. It's not bright white on T1. Easily detectable on this diffusion weighted imaging, which I'll come to in a second. But there's a second lesion in the liver which is not visible on CT. Easily identified because it's bright white. So it's a mixed population again. But if you look at the diffusion, not only can you see that lesion, but you can see the additional lesion, which I think you're really struggling to see. So this seems fairly obvious. We should just be using diffusion weighted imaging on everybody, shouldn't we? Sometimes we have these tiny little zits on diffusion weighted imaging and they turn out to be benign. But in cases like this, which is a scan repeated 3 months later, it tells us that in fact these tiny zits were in fact metastases. This is the principle of diffusion weighted imaging. That's a T2 weighted scan. You'll easily see the difference between the benign cyst and the two metastases. But if you look at the diffusion weighted image, we pick up the additional lesion, which is perhaps difficult to see. It's a particular sequence. I don't want to bore you with the physics, but this is the so-called low B value. And if you compare that with a high B value, benign lesions such as the cyst tend to disappear into the background, whereas malignant lesions become more visible, and you'll see now that we're starting to see even more metastases. It's not as simple as that though. That's a CT scan with a vascular lesion which is not visible on portal venous. It's bright white on T1. This is melanoma again. And again, additional lesions on the diffusion weighted imaging. Diffusion weighted imaging, unfortunately, is T2 weighting, so when we have lots of melanin, these lesions go black. So for example, you can see here, classic example of diffusion weighted imaging, you'll see that there are two metastases visible there, but the bright white zit you cannot see on diffusion weighted imaging. So in actual fact, it has a flaw, but not really, because they're easily visible on T1. So to cut a long story short, the way I image melanoma metastases is the T1 weighted sequence with fat saturation, they're the bright white zits, and diffusion weighted imaging. PET scan has been mentioned. We occasionally use this for colorectal cancer. This is my demonstration of a PET scan. How do you make something stand out? You do a PET scan. And cancer throughout the body tends to stand out. This patient had an ultrasound which detected a liver lesion, and it wasn't me that did it, but one of my colleagues recommended a whole body CT scan, and the patient had a whole body CT scan and it was reported as normal. When the images were reviewed, we thought there might just be something there. You'll see that on the T1 it's bright white. So this is absolutely classic of melanin. This is a patient with a known melanoma, not visible on the diffusion weighted imaging. PET scan, whole body PET scan was normal, so one of our surgeons chopped it out, and it's melanoma. And this was done laparoscopically. That's another new development in liver surgery. This was a relatively less invasive procedure. This was just keyhole surgery. It was just shaved off the liver. That was 1 year ago, and on the first follow-up sets of sequences, the patient is still disease-free. Believe it or not, that's a lesion in the lung which is bright white, which we accidentally picked up. When you check the CT scan, there is a nodule which has grown since last year. That's the nodule has melanin within it, so it's a growing nodule with melanin in it. That's a melanoma metastasis. But CT is obviously the better choice for looking at lung disease. The other problem with CT, of course, is radiation. If you want to survey someone with CT scans, it's lots of radiation. There are more pleasant methods of measuring femur length in babies than doing a CT scan. You do an MRI if you want to. So if you were going to have a vote on whether you wanted a CT or an MR, you'd probably vote for MR. The other problem with CT is it picks up lots and lots of extraneous rubbish. Every patient who has a CT has a lung nodule, a liver lesion, or an adrenal nodule. This is the biggest bane of our life at the moment. CT scan generates lots and lots of false positives. This is what I used to look like when I was younger, and this is what I've degenerated into. Permanently sidetracked and distracted by irrelevant nonsense. So you find a nodule in the lung in October 2004, you repeat it in January, etc., etc. This goes on now in our department day after day after day. So, I'm not suggesting that everyone can get what they want anytime they want it. There are availability issues, but to cut a long story short, we use ultrasound. It's easily available. At the patient can have instant access, but we have a very low threshold for going straight to MR. If there's any particular problem with patient body habitus, we don't mess about with ultrasound. We replace it with MR. But the main message I wanted to get across today was CT is, you're asking for trouble if you rely on CT. Thank you.